Thrombotic microangiopathy, every minute counts. Good morning, everyone. So, today I am going to discuss a clinical syndrome where recognition and treatment cannot be separated by time. Thrombotic microangiopathy. So, this thrombotic microangiopathy, it is not a single disease, it is a pathological process. So, this can rapidly lead to thrombocytopenia, microangiopathic hemolytic anemia, and organ injury. My central message today is very simple. Every minute counts because early recognition, so this can prevent irreversible organ damage and save lives. So let us begin with a situation that we may actually encounter in the emergency department. Imagine a 32-year-old woman presenting in the middle of the night with acute confusion. On examination, she has widespread petechiae but no obvious focal neurological deficit. Her platelet count is only 18,000, hemoglobin is 7.2 grams per deciliter, creatinine is 2 milligrams per deciliter, and cystocytes are present. So we already have three very important clues: thrombocytopenia, hemolytic anemia with cystocytes, and renal involvement. So now comes the critical question. So do we wait 3 days for the Adams 13 result, or do we start plasma exchange now? So this is the decision that can determine the patient's outcome, and that is exactly why TMA, it is a medical emergency. Then targeted action in the acute setting. So in the acute setting, I would approach the patient in 3 steps. First, recognize the triad: microangiopathic hemolytic anemia, thrombocytopenia, and organ ischemia. After recognizing the triad, stratify rapidly. So this is where the plasmic score becomes extremely useful at the bedside. And third, execute treatment without unnecessary delay when the clinical probability of TTP is high. So the important concept is that diagnostic certainty may come later, but clinical action has to begin now. So, but once we recognize a TMA, the next question is, what exactly are we dealing with? The TMA diagnostic map, navigating the modern umbrella. So this slide illustrates the modern concept of TMA as an umbrella syndrome. So at the center we have the common pathological process, so that is endothelial injury with microvascular thrombosis. So the primary causes include, what are the primary causes of TMA? Immune TTP due to severe ADAM-TS13 deficiency, congenital TTP, complement mediated HUS, and Shiga toxin associated HUS. So then there are secondary TMA. So what are these secondary TMAs? So these are associated with pregnancy, malignant hypertension, drugs, autoimmune diseases, cancer, and transplantation. So therefore, when we see a patient with TMA, we should not immediately label every case as TTP. So what is our job? It is to identify the cause rapidly, because treatment, it depends on the mechanism of the TMA. Then the intersection of the timelines. Why waiting is fatal? So this is perhaps the most important slide in the entire presentation. So look at the two timelines. On one side is a clinical timeline where organ injury is progressing from hour to hour. On the other side, we have the diagnostic timeline where we may be waiting for the ADAM-TS13 result. The problem is that these two timelines do not move at the same speed. The disease does not wait for the laboratory report. So if we delay treatment for several days while waiting for confirmation, cumulative ischemic injury can progress to a point where it becomes irreversible. So therefore, when the clinical suspicion is high, the treatment decision has to be made before the confirmatory result returns. Pathophysiology. So what is the endothelial crisis? So let us briefly understand what is happening at the microvascular level. An endothelial trigger. So this may include infection, autoimmune disease, or toxins which causes endothelial injury. So this leads to the release of ultra-large von Willebrand factor multimers from the Weibel Pallade bodies. Normally, ADAMTS13, so this acts like a molecular scissors and cleaves these ultra-large multimers. But when this regulation is lost, these very large von Willebrand factor multimers become extremely adhesive. So platelets attach to them, aggregate and form microvascular thrombi. So the central event is uncontrolled platelet-rich microvascular thrombosis. Then coming to the mechanical shear. So now we come to the second part of the story. So that is mechanical hemolysis. So as red blood cells pass through these narrowed thrombus-filled microvessels, they are exposed to intense mechanical shear. The red cells literally fragment. This produces cystocytes or helmet cells on the peripheral smear. So because this is mechanical destruction, it is a non-immune hemolysis. So therefore, we expect the laboratory evidence of intravascular hemolysis, high LDH, low or undetectable haptoglobin together with a negative direct antiglobulin test. So remember the sequence: endothelial injury, platelet-rich microthrombi, mechanical shear, cystocytes and microangiopathic hemolytic anemia. Clinical features beyond the historical pentad. Traditionally, TTP was described by a pentad. So what is this pentad? Fever, renal failure, neurological abnormalities, microangiopathic hemolytic anemia and thrombocytopenia. But waiting for all 5 features is dangerous. So in modern practice, the key triad is much more useful. So what is this? Thrombocytopenia, microangiopathic hemolytic anemia and organ ischemia. The neurological manifestations may be subtle. So these are confusion, headache, transient neurological symptoms. Renal injury may also be present without severe renal failure. So if we encounter unexplained thrombocytopenia together with microangiopathic hemolytic anemia, we should actively consider TMA and proceed with urgent evaluation. The absence of the classical pentad should never falsely reassure us. The peripheral blood film, visual evidence of shear. So this is where the peripheral smear becomes extremely important. The smear can provide some of the fastest bedside evidence that we are dealing with a microangiopathic process. Here we can see the characteristic fragmented red cells, the cystocytes. So their presence in the appropriate clinical setting, so this strongly supports microangiopathic hemolytic anemia. At the same time, we should look for features that point toward alternative diagnosis such as spirocytes. So these spirocytes, they suggest immune hemolysis or true platelet clumping, suggesting pseudothrombocytopenia. So my clinical pearl here is, do not simply wait for the laboratory report. Look at the smear yourself when TMA is suspected. The peripheral film may be one of your earliest diagnostic clues. Adams 13, molecular scissors and sticky nets. So this slide explains the central mechanism of TTP. Under normal circumstances, Adams 13 cleaves ultra-large von Willebrand factor multimers and prevents spontaneous platelet aggregation. In immune TTP, autoantibodies interfere with ADAMTS13. So the result is severe reduction of ADAMTS13 activity. The ultra-large von Willebrand factor multimers, they remain uncleaved. Platelets continue to adhere and microvascular thrombosis develops. So this explains the combination of thrombocytopenia, microangiopathic hemolytic anemia and organ ischemia. So Adams 13 is not simply a diagnostic test, it is directly linked to the pathophysiology of TTP. The plasmic gauge, stratifying risk at the bedside. When Adams 13 is not immediately available, we need a bedside method to estimate the probability of severe Adams 13 deficiency. So that is where the plasmic score helps us. It incorporates 7 clinical and laboratory parameters including severe thrombocytopenia, evidence of hemolysis, absence of active cancer, absence of transplant history, MCV below 90, INR below 1.5, and creatinine below the specified threshold. A score of 6 or 7 represents a high risk category and strongly increases the probability of severe Adams 13 deficiency. The most practical point is this: the plasmic score is a tool to support urgent treatment decisions. It's not a substitute for Adams 13 testing.